Welcome to AETCM channel. Today we are going to discuss a case of a shoulder dislocation. Shall we start? A case, a 52-year-old male presented to the ER after a slip and fall at his house, ma'am. Right now on initial 10-second assessment, his his respiratory pattern is normal. He is able to talk in one full sentence and his peripheral pulses are palpable and is conscious and oriented. So we connected to the lead monitors and we in the primary survey. The primary survey airway is patent and there is no secretions or anything, and as he is walking and coming we can say the cervical spine is also normal, and there is no gurgling, no stridor. And next, coming to breathing respiratory is 18 per minute and saturation is 98% at room air, and bilateral equal raise in the chest is seen, ma'am. In circulation, the heart rate is 110 per minute and BP is 120 by 80 mmHg, and peripheral pulses are palpable and there is no any active site of bleeding, ma'am. And in disability, the patient is having GCS of E4, V5, M6, and bilaterally equally reactive pupils are present. JRBS was taken, JRBS was 128 mg per DL. And then coming to exposure, the patient has some abrasions on the left lower limbs and no active site of bleeding, and temperature is 98.4 Fahrenheit and hypothermia is prevented by providing blanket.
What was his pain score?
And the pain score was 7 by 10, ma'am, on visual scale.
Okay. So in a case of trauma, in the primary survey, what else other than the medical case, what else we will have to check in case of trauma?
We have to check for any this C-spine and
In the airway, you will have to check for the C-spine tenderness. Along with airway patency, then we will have to look whether there can be any bleeding or any loose dentures or anything secondary to the trauma. Is there any oral secretions are coming? Those things should be checked into. And we will have to look for any facial deformities or anything that is that is making the airway compromised. Okay, and along in the neck also we will have to check whether there is any subcutaneous emphysema, any tracheal deviation, anything is there, palpable laryngeal fractures. These things should be checked, and that's how we inspect the airway. In the breathing,
we need to
other than the respiratory rate, air entry, what else?
Chest compression.
These things should be checked, and we will have to check for the
bilateral air entry.
Bilateral, we will have to chest rise should be checked. Any subcutaneous emphysema is there or not, we will have to check. Auscultate whether the air entry is equal or not. If it is reduced, that can be a pneumothorax or a hemothorax. These things also should be checked. Okay. Circulation,
any active site of bleeding we need to check.
Along with the vitals, we will have to check for any active site of bleeding is there. Okay. And in the disability, we'll check for the pain score, GCS or not. And exposure, we will have to expose the patient completely, and we will have to look for any other injuries. Where all should we check for the injuries? In a trauma victim, this patient had a slip and fall. Otherwise, if it is a trauma case, where all should we check?
Exposed areas, abdomen, chest.
The blood collection mostly can either be in the thorax or in the abdomen or in the pelvis or in the floor. So we need to inspect the back also. Okay.
And then the secondary survey, ma'am. The history wise, he is having the left shoulder pain following a slip and fall in his house at around 5 p.m. And on examination wise, head to toe examination, coming to the specific shoulder, we need to inspection wise, we need to expose both the
shoulders. So he is having only an isolated shoulder injury, nothing else.
Isolated shoulder injury with abrasions at bilateral lower limbs.
Lower limbs. Okay. So other systems, nothing. You could find nothing. Okay.
Yes.
Okay.
So on first inspection wise, we need to expose both the shoulder joints and compare them. And on inspection, the left shoulder joint looks displaced towards the lower side compared to the right shoulder joint.
How should we expose this patient? Like you're planning to examine this patient. So first you will have to introduce yourself. You will have to explain him what you are planning to do. If it is a female patient, you will have to take a female attender with you, and you will have to undress the patient and compare. First we will be inspecting. So from where all will you inspect the shoulder?
From anterior and lateral.
From first we will have to inspect the shoulder. from anteriorly we will be looking whether there is any deformity, whether the alignment is same or the any muscle wasting is there, any swelling, bruises, any scars, anything. If it is visualized, that should be noted. Those things should be examined from the front, from the sides, and
from
behind.
the
Okay.
on anterior side examination, the contour of the left side is a slight lower
Reduced.
compared to the right side, ma'am. That is inspection wise. And the palpation, next we do the palpation. In the palpation wise, we first feel the glenoid, acromial joint, acromoclavicular joint, and the glenohumeral joint, and claviculo-scapular joint. These three. Here the acromoclavicular joint looked highly prominent, ma'am. And the shoulder, this head of the humerus lower, like freely floating and not in the socket, like.
Okay. Okay.
The palpation. And we should first, in the primary survey itself, we had given him a painkiller of PCM, so that after.
So before palpation, every patient we will have to offer analgesic. Okay, okay. So analgesic should be offered, then we will have to palpate. First palpation, we should check for temperature. So this patient is a trauma, so we are not suspecting anything in terms of a joint infection. So temperature, then we will have to examine for tenderness. So first we will have to palpate the bony prominences, then followed by we will have to do the other things, and we will have to do the in the movement when we are examining, active and passive movements should be checked, and then we will have to do the special test. Okay.
Along with that, in this case, even the sensation regimens and to check the axillary nerve, is it intact or not across the shoulder, was also tested. Is still preserved only.
Okay, okay.
And then active and the passive movements, we asked him to externally rotate, abduct. The patient is fixated in external rotation and abduction. He was not able to move. He is using the support of the other hand to catch his left hand, ma'am.
Okay. What are the other additional tests we will be doing?
Additional test in this case, first we'll
Regimen bad sign is absent. Then
we'll ask him to touch hold the other shoulder joint with the same hand. And the other is Dugas test, and the other one is Hamilton Ruler's test, in which the acromial head and the this elbow, if they're in the straight line, it says that the shoulder dislocation is present.
Okay, all things will be difficult if the patient is having pain. Okay,
so we need to offer analgesia.
Okay, okay. So then what was done for this patient?
Then X-rays were taken. Initial X-rays of left shoulder AP view and Velpo view, ma'am.
How will we take this AP view?
AP view. Patient standing in front of the X-ray, projected from the anterior side.
Okay. And how will we take the Velpo view?
When Velpo view is taken, when the patient is not able to abduct, so that to take the lateral view. So we ask the patient to incline 30 degrees, and we'll take from the posterior mid-side laterally this.
Okay. How will we take the scapular Y view?
Scapular Y view after abduction and keeping the scapular as the lateral in the center of the frame, we will take.
Okay.
That view is
so what do you see in this X-ray?
In this X-ray, this is the glenoid tubercle, and this is the head of the humerus, which should be in the place, but head of the humerus is down, like anteriorly dislocated. It can be the subcoracoid. In the anterior dislocation, there are three types: subcoracoid, subglenoid, and subclavicular and intrathoracic.
Okay.
This can be a subcoracoid.
Okay, okay, okay. Okay, fine.
After the X-ray views are taken, as seen, we have found that there is an
So you have confirmed that there is no axillary nerve injury. But what about the peripheral circulation?
Peripheral pulses are palpable, and even checked right now, as he is in pain, he was not able to abduct, and the active range of movements can't be tested. Only passive range of movements were tested.
Fine.
After which, planned for the shoulder this like reduction procedure, ma'am. So for that we had to provide sedation, like procedural sedation. In this case, we had offered midas plus ketamine.
before planning to do a procedural sedation, what else should we check?
First, we need to connect to the monitors and check all is hemodynamically stable and everything, and we need to inquire his past medical history to see whether the drugs can be used, which drugs can be best selected. At the same time, we have to make the crash cart available, intubation. If there is any case of crash, we need to be readily evaluating. As it is a prepared planned procedure, we need to even assess the risk of the intubation, and all the risks should be categorized, and as per that, even the if there's a difficult intubation, for that also everything should be arranged.
Okay, and all we should take a informed consent
Informed
also.
consent.
So in the airway, we'll have to start him on oxygen either through a nasal prongs or a face mask. We'll have to start, and all the monitors should be corrected. There should be 2 large bore IV cannulas.
Cannulas.
Cardiac monitors should be attached, and continuous monitoring should be done before the sedation, during
During the
sedation,
sedation,
and
after
after the
the
procedure.
sedation,
Okay. So what was done? What was given to this patient?
Midas plus ketamine, ma'am.
What was the dose?
Midas for 0.5 mg per kg, 2 mg was given, ma'am, and ketamine 0.5 to 1 mg is the dosage, so 20 mg is given, ma'am.
20 mg. Okay, okay. He requires slightly. Okay, fine. Then how did you do the reduction?
Reduction, 2% procedure, ma'am, in which one person gives the traction from the same side of the hand, other person from the opposite side covers the patient like thorax with the blanket and pulls. The other person both traction, and then we hear a click sound indicating the shoulder fix.
So what all first traction should be given. Who will give the traction?
The person who is standing from the same
Patient who is a person who is standing on the side of the injury should give the traction. Other person will be giving counter traction by covering with the covering with the blanket, and other person will be doing the counter traction.
Then abduct.
When we do the counter traction, simultaneously one external rotation will be coming. Then there should be abduction and internal rotation. So traction, counter traction, external rotation, abduction, and internal rotation. Okay, that was done. And was it okay?
It has fit into place, as this is the first time. This is the first time he's having a shoulder dislocation, so we had to say educate him about there can be chance of recurrent shoulder dislocations, and prevent him from abducting or external rotating within the following 2 to 3 weeks.
Okay, so immediately after reduction, we will have to place the arm on an arm sling, and we will have to take a check X-ray. And before shifting for check X-ray, we will have to check the peripheral pulse also. So first we will have to immobilize the limb, check for the peripheral pulses, then we will have to check the check X-ray. What other immobilization techniques can be done? Okay, fine. What other reduction methods can be practiced?
Coacher's method, in which they will follow the traction, external rotation, abduction, and internal rotation. Single person's method. Another is Hippocrates method, where the patient is left supine and with the leg which is reduced.
Okay. Then there is Simpson's method, where one weight 20 kg weight is put like that. Then different methods are there. Milch method. These methods can be done. Or external rotation technique. If the patient, other than doing this, if the patient is asked to external rotate the hand, it might sometimes fit into place. Okay, so these things can be done. So when should we ask the patient to come back to orthopedic OPD? Should we give orthopedic consultation from the ER?
We should give consult, because after anterior dislocation we need to check for if there is any rotator cuff tear or any other before.
Okay, when all will you call orthopedics? If it is like an isolated shoulder dislocation, if there is nothing else, we can itself reduce, and we can immobilize and discharge the patient and ask him to review in orthopedics OPD after 2 weeks. But if it is like, if the patient is having an associated arterial injury or any sensory differences there, or if the patient is having associated fracture, surgical neck humerus fracture, associated fracture, these things and all, we will have to call orthopedics. And if it is a recurrent shoulder dislocation, what is the other complication that we should expect?
Recurrent shoulder dislocation, you have mainly Hill-Sachs sign and Bankart's lesion available. Hill sacks is the finding on the humerus because of the labrum being rubbed across the humerus. And Bankart's is on the labrum of the glenoid, where it can be bony Bankart or normal Bankart. Bony Bankart would be even having the scapular fragment.
Okay, so Bankart lesion, Hill-Sachs lesion, these should be suspected, and in such cases also we will have to plan on a definitive repair of that. So for that we need either an MRI or something to diagnose whether that lesion is there, and depending on that surgical treatment should be done. Okay, so this patient, it was the first incident. Okay, so you immobilize the patient. Do you have the check X-ray?
Post X-ray, it is in the place.
Okay, it is in the place. Okay, and how did you discharge the patient?
Discharged with the sling and analgesics given, anti-inflammatory medication also given for the next few days, and 2 weeks of immobilization and avoiding any external rotation or abduction kind of activities.
Okay, okay. Thank you.